Hi dear friends, welcome back to my channel. I will started a new series on nephrocritical care where I will be speaking on various topics related to acute kidney injury and renal replacement therapy also. Today in this video, I will discuss how to perform diagnostic workup in a patient who is detected to have AKI. So after you have already identified rising creatinine and drop in urine output, now this is the time to go for diagnostic workup to find out the etiology of AKI, which is essential to guide the management and potentially reverse the disease progression to AKD or CKD. Remember that in critically ill patients, the most common causes of AKI are sepsis, which is number 1, systolic heart failure, hemodynamic instability, hypotension, hypovolemia, and exposure to nephrotoxic substances. Now all of us know the etiological classification of AKI. The terms prerenal, renal and postrenal have traditionally been used to narrow down the differential diagnosis of AKI. Be aware of the fact that AKI etiologies do not respect this traditional boundary of renal, prerenal and postrenal categories, and pathologies coexist. So, in the same patient, you may have prerenal, renal and postrenal etiologies operating together. Several studies have demonstrated that acute tubular damage, which is basically the renal component, may be present in patients with prerenal AKI who may have poor cardiac functions. People have debated a lot over it. The current consensus has proposed to differentiate the functional AKI from kidney damage and not the traditional etiological terms. Now, what are the various diagnostic tests you should perform in a patient with AKI? Never forget urinalysis or urine dipstick testing, which is an examination of the urinary sediment. And never forget to order imaging studies like ultrasound, KUB and renal Doppler. Urine dipstick testing is very important and should be performed in all patients as soon as AKI is suspected or detected in order not to miss any potentially treatable glomerular or tubular pathologies. Urine dipstick testing detects blood protein, leukocyte, nitrites and glucose. In India, we ask for urine routine examination. If you find hematuria and proteinuria, that means there is glomerulonephritis. Acute pyelonephritis is diagnosed when there is a pyuria or leukocyturia or nitrites in urine. In interstitial nephritis, there will be eosinophils in urine. All above urine dipstick results should be interpreted alongside the clinical context or clinical background. For example, in a crush injury patient, a urine dipstick testing positive for hemoglobin without red blood cell positivity suggests a possible diagnosis of rhabdomyolysis. Sometimes urine microscopy clinches the diagnosis in rare cases of AKI. For example, in case of tumor lysis syndrome, urate crystals may be present. Urine biochemistry is less helpful to differentiate kidney damage from functional AKI and also challenging in critically. Renal ultrasound is very helpful, very useful for evaluating existing structural renal disease and diagnosing obstruction of urinary collecting system. Reduced corticomedullary differentiation and decreased kidney size is indicative of underlying CKD. Renal Doppler ultrasound may be used at the bedside to estimate the renal perfusion. Ultrasonography can also be used to guide the percutaneous drainage of obstructed upper urinary collecting system, and also it can be used for renal biopsy when there is a doubt in diagnosis. Sometimes the CECT abdomen may be necessary to evaluate the anatomy or function of urinary tract. Therefore, the risk of contrast administration must be balanced against the benefit to be gained by this investigation. Now, what is the role of intra-abdominal pressure monitoring? Well, in case of suspected AKI due to intra-abdominal hypertension or compartment syndrome, serial measurement of intra-abdominal pressure should be considered. If it is more than 20 millimeter of mercury, compartment syndrome may be definite contributor to the development of AKI. sometimes we have to see autoimmune profile depending upon the clinical context. The autoimmune profile should be considered mandatory in patients with AKI presenting primarily with the pulmonary renal syndrome or hemoptysis or hemolysis or thrombocytopenia. If an autoimmune cause of AKI is suspected, then a nephrologist referral will be needed to assess the treatable condition appropriately. Now, there are a few additional tests that may be indicated depending upon the clinical context, such as serum creatine kinase and myoglobin in case of suspected rhabdomyolysis, LDH in case of suspected thrombotic thrombocytopenic purpura, NT-proBNP and troponin in case of suspected cardiorenal syndrome, serum urine protein electrophoresis in case of suspected myeloma kidney. So that's all for today. Thank you so much for your attention. Bye bye.